All right, sorry for the delay. So it's generally helpful with these if I could get some photographs of a high smile line and a digital impression. Be very helpful. So I see she's in a crossbite here. Ideally, we like to correct these, but as you see, she's skeletally set back in the maxilla. So yeah, we might be able to get her an edge-to-edge situation, but I think that might be it. Yeah, she had this implant placed. It's too high, so we're going to remove it and replace it, because if you see the bone loss here, as you look down this way, we're going to have to level the bone off all the way down here. All this is going to go. So this implant's got to go below it. So that implant's just going to be thrown away. Okay, but let's talk about the top first. So top implants seem more reasonable in terms of their positioning. The only unfortunate thing is, if we're going to fix this crossbite, if we could set her back on the bottom a little bit and bring those upper ones out a little more, then we might be able to work with it. I may remove these back implants on the left side, even though, well, this one's coming out of the, this is probably coming out of the facial a little bit. All right, we're gonna take this one out for sure. We might take this one out also, and I would angle an implant here and exit the same spot. Place another decent bone here, decent bone here. Yeah, so we have good support here. Let's see, I'll put one more in the lateral space. I can fast forward through this, but I'll do the plan quickly. And we're going to add implants for you. You are using the MIS, I believe. Mine was the V3 implants. I believe so. All right, so let's say a 3.9 or a 4.3 by, let's say 13. And you're going to tell me if this is an immediate load situation or not. It's tight bone here. Let's switch that to a 3.7, 3.9. Okay, a little better. Let's add a multi-unit abutment. They don't have multi-unit abutments saved here, but I'm assuming the system will have a multi-unit abutment. We'll switch that out. We've got to get the implant information for these implants and get multi-unit abutments on these. Again, I would probably use 3 of these, not all 4. Maybe skip this one in the middle. Just because there's too many multi-units, it makes a prosthetic too thin. So that's here. We'll put another one, let's say here. That looks pretty good. The incisive canal that you're looking at here is not a big deal to invade. It's not going to make anyone's life difficult. Okay, that's that. And that's almost going into the nasal septum, which is fine. Our nasal spine here, not really the septum. That's solid bone. We use that all the time. I may even make that implant longer to grab onto that more. Okay, this implant kind of sticking out of the bone, but it might be a good spot. But it's too low. All right, we'll see about this one. But this one's kind of low. So I might ditch this implant then, because we need enough height to make a nice flat prosthetic here. This one's a drop low. Even though it's a solid implant, it's good for a bridge, just not good for a all-on-X device. So I might lose that one. Here. So maybe let's spread this guy out a little bit more. If we're losing this one, I'll have the lateral space, and then we'll put an angled here. Say 4, 3, 13 or 16. Ride that medial wall of the sinus, we're fine there. Let's maybe straighten this guy up. Okay, I'm comfortable with this. Let's maybe see if we sneak a pterygoid in. Take a look at the pterygoids here. And this is more of a me part. You could skip this if you need to. There's the bone we're grabbing. What's called the pyramidal process here. That's what gives us our nice basal bone and anchorage. I'm kind of passing the sinus to get to it. We'll see, we'll keep that as like a backup implant. This just allows us to not have a cantilever. But actually, when we're going to go across here, we'll even be in the sinus cavity on the floor here, which again can be done if necessary, but to me that's might be overkill. All right, let's kill that. Because if you look here, where this is going to exit, I'm going to be here, but where this is going to exit, I'm going to be here. We got to bring this way up. If I do that, when we level, we're going to be already into the sinus cavity, which again we can do. It's not like it's a contraindication, but it just can bring along complications that are unnecessary. Yeah, because we lost so much bone here, we've got to be this high. Yeah, so again, it's not worth the loss here. So let's remove that. Okay. And let's bring that back to where we were. And these implants are about right. This one will go. All right, so we're looking at an additional 3, maybe 4 implants. And I may even use this spot still. I got to know age of this patient, the force of the bite, things like that. It would tell me if I'm going to put another implant here. I only have 2 on this side, and I've got plenty of support here. These are sinus implants, so they're not quite as strong, but we've got enough of them that will be fine. I might want to sneak one more in here. So let me know about if we have high forces of mastication here. All right, so that's the top. Bottom, this implant maybe we'll keep. This one will go. And we'll just put a standard all on 4 down here. If we have that one, I don't have to angle anything. We just put one down here. Back to the MIS implants. Not MSDI, MIS. And just remind me the implant type. replace that with a maxillary implant. And then we'll have a conversation about need to immediately load here or not. If we're not going to immediately load and you want to put in a denture, we can actually use this implant temporarily with a denture. That might not be a bad idea. Restore it, put a crown on it, or a locator on it, and use that for a temporary denture. I like doing immediate load, but I understand in Israel it's a little more complicated. Definitely not narrow or a standard. We have room for a 4.3 by 13. Good. Duplicate that implant here. There's our nerve coming out. Here's our nerve. A small anterior loop, so we're about here. So if we're going to use that one temporarily, the only problem is I can't do my bone leveling if I keep that implant temporarily. All right, so let's scratch that. We'll go with a full denture if we're not immediately loading. And I'll angle this last implant. And I'll refine that slightly, but that's basically where we're going to be. We even have room for an implant back here. Let's say a 43. Let's call it an 8. Maybe even a 10. Let's try a 10. Yeah, you technically have room for a 10, but let's make our lives easy. Let's make it an 8. Okay, so process here. Again, if you're comfortably loading, I'm very happy to do that. If you want to do it digitally and mill and print, that's all great. I can help guide you through the process of that. I just haven't done it in Israel to any reasonable degree, so let's just figure out how the laboratory process would work there. But if you're doing delayed, extract, level the bone, place the implants, wear a denture, this tooth goes also, and we come back in 3 to 4 months, uncover, place multi-units, and to take impressions and have a prosthetic made. That is our process. Okay, fees. So again, in Israel, it'd be helpful for just if we're doing a lot of these to give me, if you have colleagues that are doing these routinely, what's the going rate in Israel for arches? Because I like to have a flatter fee, not getting so particular about all the details of what we're doing, how many extractions, how many implants, because if I need extra implants, I put them. If there's not room for extra implants, I don't. It's much better just to have a flat fee and just fluctuate based on the complexity of the case and the complexity of the person, because the complexity of the person is going to play a big part in arches. But generally, let's say in the States, it's mid-average or mid-average is about $35,000 per arch, surgery and restorative. So we're saying between $60,000 and $70,000 for the case. We have some wiggle room there, obviously, so we could be in the $50,000 range, but we're in about the 100,000 shekel a arch. Sounds reasonable to me. Let me know if that works, and that's it. We have a plan. Okay. Again, let me know the rest of the details of the patients. We'll talk about that, but this way you have what to present on Monday. All right. Thanks so much.